Faith-Forward Media, this is Healthcare Musings. I'm Dr. Hashem Hasabala. Welcome everyone to Healthcare Musings. I am very delighted to have Dr. Chailee Moss of the Center for Vulvovaginal Disorders in Washington, D.C. on Healthcare Musings. Just a little bit of background. Well, first, welcome Dr. Moss to Healthcare Musings.
Thank you so much for having me.
Absolutely. Thank you for being here. Thank you for your time. So Dr. Moss and colleagues published an article in the JAMA Network Open. It was published May 8th. And what kind of took me aback a little bit and wanted to discuss with her further, the article, and I'll put the link to the article in the show notes. It says experiences of care and gaslighting in patients with vulvovaginal disorders. And we'll just start right. First of all, congratulations on the article. I know it's a lot of work.
Yeah. It's a lot of work, but definitely a labor of love because we hear these stories all the time from patients and really wanted to figure out a way to quantify them because there's so much power in numbers, I think.
Yeah, yes, absolutely. And so we'll just go right into it. You coined the term, or you used the term, medical gaslighting, and I've always struggled with what gaslighting means, and I think the article really does a good job in explaining what gaslighting is. And so if you can just explain what is gaslighting and what you meant by medical gaslighting, which is really what raised my eyebrows and wanted me to reach out and discuss the paper with you.
I think so. We use the term the way that it had been used by others, actually. We use their definition. I think historically, gaslighting has been when comes from the movie Gaslight, which was a movie that's an old film classic in which it's a husband and wife, and the husband keeps turning up the temperature to make the wife saying it's warm, and he keeps denying any knowledge. So that's the historic sort of meaning of the term, which was to deliberately make someone feel crazy by discounting their account of what's going on. And I think in the historic context, it was in a situation where you knew you were it was malicious, right? Like maliciously not listening to someone's account of what's going on and discounting it in a way that made them feel crazy. It has been taken in sort of colloquial usage out of that specific definition, I think. And in the medical context, we hear it from patients, and it has been sort of turned into a term that refers to discounting patients' account of their own illness and not properly evaluating their concerns. And so in the vulvovaginal disease space, we see it in patients who are saying, I have pain with intercourse, I have pain with using tampons, I have pain with exams in the clinic, and providers saying, oh, it's okay, it's just your stress, or it's just the way things have to be in menopause, or it's, because you're anxious, and not sort of validating the concern and investigating it as a problem. So that was sort of so we sort of took this sort of colloquial usage of the term, the way our patients were using the term, and said, okay, like how can we quantify what this is and evaluate it with an eye towards the concerns of our patients? There's this idea of epistemic injustice, which is injustice related to knowledge and knowing. And I think that this idea of gaslighting is really a granule of the larger idea of not honoring the patient's accounts of their own experience with illness.
Wow. Thank you. So can you kind of go into what the paper found, what your point of the paper is, and for those who haven't read it, and what were your major findings of the paper?
Yeah, our hypothesis was really that these kind of behaviors that patients reported in testimonials through the National Vulvodynia Association and in sort of other forums where we heard patients talking about this, was that those behaviors were common, but we wanted to quantify them to kind of test that hypothesis. And so what we did was we took the accounts from the National Vulvodynia Association where patients sort of talk about their experiences, and we we extracted themes from those experiences. And then we posed, we sort of created a survey. We asked 2 national organizations if they felt like these were the concerns that they heard from their constituents. And then we sort of asked our patients, how often are you experiencing these behaviors from the clinicians you've seen in the past, and how distressing are the behaviors to you? And what we found is that these behaviors are really common, and not that that the behaviors are often so distressing that patients consider giving up on care. Over half of the patients that come and see us said that they'd considered giving up trying to get help because they just didn't feel like they were going to get help. And probably that we think that that's related to some of these behaviors. So patients were made to feel crazy. And, you know, like 39% of our patients said that at some point in the past, when they're seeking care for their issue, they'd been made to feel crazy. And that, like, you know, over 40% of our patients have been told to relax. And, you know, there are over 16% of our patients felt like they had felt unsafe in an encounter with a healthcare provider. Now, we see patients who, you know, because we're a referral source, we see patients who've been to numerous clinicians. So they have probably more engagement with the healthcare system than your average gynecology patient. And that may mean that these numbers are not fully representative of the general experience of patients in gynecologic care or in care in general. But the way that it's been sort of received, I think that these behaviors are really common. They may not be as common in our as they are in our population, but I still think they're very common.
So do you think what really shocked me was 20.6% of the respondents to your survey was told you need a glass of wine or to drink alcohol.
Yeah, or a similar suggestion. So it may have been told that they needed a glass of wine, that they just needed to, in some cases, people who are having pain with intercourse are told that they should have more intercourse, that that's the solution. It's like saying you have a cold, stop coughing. Like that's the solution to your cold, is to stop coughing. I mean, it seems crazy when I'm saying it, but we hear it from patients all the time. And so I think the practice changing part of it is just like, it is very easy to not say that to a patient in gynecologic care, to not say that they should use a substance, or that the problem is just not engaging sufficiently frequently in the behavior that causes them pain and harm, right? Those are very easy things to change in terms of our practice. And I think it's definitely, I'm glad that it jumped out to you, because I think it's one of the most important things in the paper, just to highlight like, hey, don't do this. It's distressing to patients and it doesn't help them.
Right. So do now obviously you're, like you said, you're a referral center, so there's a little bit, and you mentioned this in the paper, there's a little bit of selection bias or referral bias, right? Because it's,
Right.
you know, you get people who have been at, it says on average 5.5 clinicians before coming to see you, right?
Yes.
So they've been around the block, so to speak, and so it's may not be generalizable to the general population. And
Mhm.
at the same time, I think it's important. What I took away also was important not to dismiss what the patients are saying and to hear them. He, because I was talking to a colorectal surgeon, he says, you know, sometimes he'll have people with pain, but there's nothing physical that he can find to do, and he doesn't want to operate on somebody that he can't pinpoint something physically and say, well, this is what I'm going to fix with surgery. You know what I'm saying? So is it really, I mean, do you think it's malicious on the part of clinicians, or they just can't find anything and they don't know what to do?
Right. I don't think it's malicious. I think it's a combination of a lack of time and a lack of knowledge. I mean, I've said this to a number of people who've asked me about this article. I don't think any of us get into medicine, you know, everybody I know that went to medical school got into it because they wanted to help people. And nobody wants to harm people by dismissing them. I think there's partly a culture where we're told inherently to doubt people, right? You're a second year medical student giving a practice presentation on your rotations before you're even in clinical practice, and you will be told not to say things like the patient has pain in their right upper quadrant. You will be told to distance yourself from the patient's story by saying the patient reports pain in their right upper quadrant, right? We're inherently sort of infusing doubt in the way we relate patient stories. So I think that's part of it.
I've been told trust no one. I mean, I've been told
100%. Yes, I've been told that too.
by
And
my attendings,
why?
trust
I mean,
no
I
one.
just think in the vast majority of cases, patients are not motivated to deceive us. And so I know that we are trying to be a scientific discipline. And so we should have healthy skepticism about aspects of clinical investigation. But I just don't know why patients' subjective experience should be on the chopping block. And I think sometimes it is. And so I think there's this like infusion of like doubt patient stories, don't trust anything that patients say. And then there's modern medicine, which gives gynecologists 15 minutes for a return gynecology visit with a patient in a sort of traditional practice setting, and very little training and expertise in vulvovaginal care, especially disorders that relate to pain with sex. We are siloed in OBGYN residency between like life-threatening things, right? Someone's bleeding to death and they need a hysterectomy. Someone has a cancer and they need a hysterectomy for that. An ectopic pregnancy, obstetrics, where we have lots of life and death things. The nature of our residency training is that we are in the hospital a lot, but it means that these day-to-day things that have a significant impact on the life of our patients is not centered in OBGYN training. And so if you come out of residency training, you have maybe 30 minutes with a new GYN patient who has, a years-long history of pain. You've had very little training in order to help them. And there's this culture of like, I'm not sure about the patient story. I think it can be easier, we're all human, to doubt what's going on with the patient and maybe cast some doubt to them about their story than it is to say, I don't know, and I'm going to have to do and there's a lot of effort involved in me figuring out what's going on.
Yeah, right. And I think I'm glad that you included like some of the narrative responses that patients put into it. It's very eye-opening. I encourage everyone to read the narrative responses, because that's also gives you kind of an insight into what is being told by them. And I think that what I want to write actually back to the journal, but I can't help but ask. So when in this, can you link what like a specific diagnosis that was eventually found in these patients to what they said, or the dismissal of their symptoms, like, oh, it's nothing, oh, you're anxious, oh, you need to drink more alcohol,
I
and
see. Sort of saying like
you know
they
what I'm
were
saying?
told in the past that they should drink more or address their anxiety, and they came to us having objective evidence of something like lichen sclerosis or lichen simplex chronicus or lichen
Yes,
planus. I can't do that. We didn't do that within, like, we don't have the like sort of database built into our electronic medical record to then sort of prospectively look at their diagnoses. But I
right,
think that's a really great point. And I think that's one of the problems is that sexual medicine as a discipline, I think some of these questions are undecided, right? Like someone who comes to us and we would say has pelvic floor muscle dysfunction and hormonally mediated, pain, may go to someone else and be told something different. We try to be as rigorous and evidence-based as possible, but there are some disagreements in terms of diagnoses and treatment within our discipline. So, I think the point we were trying to make in the paper is that 500 almost 500 patients came to us with pain, and they felt like they were repeatedly dismissed regarding their medical concerns. So I don't know that the actual diagnosis is as important as like, hey, don't tell people to have a glass of wine when they're having pain with sex. And even if you can't identify something, like your colorectal surgeon friend can identify something focal on exam, that doesn't mean, patients hear, oh, everything looks normal, and they think that that means that their pain is invalid. And it's more important to say what you're experiencing isn't normal. I can't see anything with my eyes, but it doesn't mean there's not something there, and we're going to have to investigate other avenues to treat you.
right. I think right. So I think, yeah, and kind of the larger context. This is, I think, this paper. I'm glad you published is bigger than just in gynecology or
Right.
in sexual medicine. I think it's more of as an intensivist to listen to patients and make them feel heard, even if maybe necessarily I can't do anything to help them. Like someone comes in and I can't necessarily cure
Right.
what's happening. Listening to them and not feeling. I mean, I remember prior to being full-time intensive care, I was in pulmonary medicine, and I had a patient who he ended up having a thymoma, right? And everyone kept blowing him off. Everyone kept blowing him off. And I finally like, well, let's just look. And he ended up having a thymoma that we resected. And I think he got a little bit better. And at the same time, what was so relieving is that that I believed him, right? That I didn't just say, oh, he's drug seeking, or well, and there are people who are drug seeking, there are people who are malingering, there are people who there is secondary gain. And I think one or two experiences in the past will color our future, right? And will project those previous experiences. And I think
Yeah.
something important is just to really listen to our patients and make them feel heard. Yes.
Right. Yeah. And again, there can be disagreements, right? Your clinical expertise may tell you, like, hey, this doesn't seem like it's an infection. It doesn't warrant antibiotics. I'm not saying you're not having pain. I'm just saying that the objective evidence I have is not that that's going to help you, but we will keep investigating what can help you, right?
Right.
And I think the hard thing as a clinician is feeling like, if you disagree with a patient about the diagnosis, then it's going to be that you're blowing them off, and you really have to make your clinical reasoning clear.
Right. Oh, so if we disagree with the patient, because I can, right? I can say, well, I don't think this is exactly what you have. And it's just
Right.
important to make sure that they feel heard, right?
Yeah. 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 And and share the decision about the treatment plan. And the other thing is, like, I think patients in vulvovaginal care, a lot of times in gynecology care, we know that medications that work on the brain for anxiety and depression, the brain is just a big center of nerves, also help with peripheral nerve pain. But if you tell someone, I'm going to give you this antidepressant for your pain, then it gives the message that you're treating them for anxiety or depression and not for pain. And what I say is, like, these medicines have been shown to help with pain in nerves. I'm not giving them to you because I think that the root of your problem is anxiety or depression. I'm giving them to you because they are an evidence-based treatment for pain in nerves. And so you do have to make that clear as well, because I think that can be a real pain point for patients as well, when they feel like, no, this is like a physical problem, and why are you treating me for a mental problem? Mental and physical are not really dichotomous, as we know,
Right.
but for patients that can feel really dismissive.
That's a great point, is that some of these antidepressants are nerve acting medications, and that's why you're doing
Yeah,
it. Yeah, yeah, yeah.
yeah,
That's a fantastic idea. That's
yeah,
a
yeah.
fantastic thing. That way you're not, because yeah, if I'm giving you I'm just picking up Prozac, or I'm giving you Zoloft.
Right, amitriptyline would be a classic, right? We give tricyclic antidepressants. We're not giving them to people because, at least in my practice, because I think that they have anxiety or depression, unless they tell me that they have those concerns. But I'm giving them to like for pudendal neuralgia. So they may have a nerve injury or pain, and it may help with it. But it feels like I'm just treating them for anxiety, depression. That can be really, really upsetting.
Yeah, that's a fantastic point. So again, this is a great paper. I know it's not a validated metric, but you have to
Right.
start somewhere, right? You
Right.
have to.
Yeah, and I think it's like a real frame shift in terms of starting with patient experiences and trying to survey what patient concerns are. It's not perfect. There are flaws in any subjective, collection of data like this, but I think it's a good place to start. And I'm glad it's at least starting a conversation.
Yeah, and just make sure that whatever specialty we're in, whatever clinical context we are, in which we are, we should hear make the patient feel heard, and then, yeah, explain what we're doing, and if we don't necessarily agree, explain why. And I don't see it, but I hear you, and let me see what we can do to help.
Yeah, and if I don't know, it's because of a limitation in my knowledge, not because of an error in your account of your symptoms.
Yeah, that's a fantastic point. Dr. Chailee Moss, thank you so much for your time. Thank you for publishing the paper. Thank you for everything you do for your patients.
Thank you so much for having me.
Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.